Hi, my name is Dr. Richard Lipton, and I am a neurologist at the Albert Einstein College of Medicine, where I also direct the Montefiore Headache Center. I'm very happy to be here with you today to talk about Gepants and their role in the acute treatment of migraine. This has certainly been a remarkable few years in migraine management, with many new treatments emerging, both drugs and devices and behavioral strategies. And today I'm going to be sharing with you the therapeutic opportunities that are created by this class of drugs called Gepants, which are CGRP small molecule receptor antagonists. My disclosures are listed here. The most relevant for this presentation is that I do consult and conduct studies funded by AbbVie, which is one of the major companies making Gepants. I also consult and conduct studies sponsored by Biohaven, and I have some options in Biohaven, and they're the other major manufacturer of Gepants. So our learning objectives today are to first outline the burden of migraine and continuing gaps in diagnosis and treatment, and I'll do that relatively briefly. Then we'll talk about the mechanisms of action through which Gepants and CGRP targeted monoclonal antibodies work to relieve migraine. And then I will talk about the evidence and the roles for Gepants and the ways that you might consider using them in the headache patients you may see in clinic tomorrow or next week. So this is an overview. First, burden of migraine, then what are Gepants, then Gepants for acute treatment, and then prospects for new migraine treatment paradigms using Gepants. So the burden of migraine by the numbers, there are 39 million Americans who have migraine, one of the most common neurologic disorders in the US and in the world. We spend $36 billion annually on migraine, and those costs include both the direct medical costs and also lost productivity, both absenteeism and reduced productivity at work. The overall healthcare costs are 70% higher in families affected by migraine than in families not so affected. And according to the Global Burden of Disease study, migraine is the world's second most disabling disorder from the perspective of lost time due to disability. So migraine is a major problem no matter how we measure it. Here we're looking at rates of diagnosis of migraine. So on the left, we're looking at people with relatively low migraine frequency, 0 to 3 monthly migraine days. And what we see is that of everyone who meets a research diagnosis of migraine based on questions that we ask who apply the ICHD-3 criteria, 44% have not received the medical diagnosis. And when we look at a group with more frequent migraine, 4 or more monthly migraine days, there we see that the rate of no diagnosis is 31%. So this tells us two things. Migraine is underdiagnosed, and as headache frequency goes up, rates of underdiagnosis go down. We continue to have a significant problem with inappropriate use of acute treatment. Guidelines recommend triptans and ergots, but when we review the data, we see there is widespread use of both opioid and barbiturate-containing combination of ingredient products. So one study found that 46% of adolescents with headache receive an opioid prescription. In a population sample of adults with migraine, we identified 4,700 people who took any acute prescription drug for migraine, and of those, a full third used opioids. And in addition, there is a condition called acute medication overuse where people take more than 10 days per month of drugs like triptans, barbiturates, opioids, or more than 15 days a month of simple analgesics like NSAIDs, aspirin, and acetaminophen, and a full 15% of adults with migraine met criteria for acute medication overuse, which we know is a factor that can exacerbate pain. So there are many unmet needs in acute treatment, and triptans have certainly become the standard, most widely used acute treatment for migraine in the US and in many countries of the world. There are people who simply don't respond to triptans, and that's a little more than a third of people with migraine. There are people who can't tolerate triptans for one reason or another. There are many people who experience recurrence with triptans, meaning they take a drug, they get relief, and then within 24 or 48 hours, the headaches come back. Triptans have cardiovascular contraindications in labeling and also precautions. Our estimate is that 3.5 million Americans have cardiac contraindications to the use of triptans. And as I alluded to already, medication overuse is a major problem in migraine. It's a very common neurologic condition, and it is often iatrogenic because the drugs that are overused are often the drugs that we prescribe. So with that brief introduction to the burden of migraine and to unmet acute treatment needs, let's talk about Gepants. Gepants are small molecule CGRP receptor antagonists. And just to remind you, CGRP is a peptide neurotransmitter that's widely expressed in the central nervous system and in the peripheral nervous system. It's found in sites that are involved in migraine pathophysiology. So if you look at the cartoon on the right-hand side of the slide, at the center of the cartoon is a trigeminal neuron whose cell body fits in the trigeminal ganglion. What is depicted here is that CGRP is released at both ends of the pseudobipolar neuron at the blood vessel and the meninges, and when it's released there, it produces vasodilation. It's also released at the central synapse, which sits in the trigeminal nucleus caudalis, often referred to as the trigeminocervical complex, and it plays a role in the mediation of trigeminal pain. There are many pieces of evidence that indicate a link between CGRP and migraine. As I mentioned already, CGRP is located in regions appropriate to the understanding of migraine pathophysiology, the regions I just reviewed with you. In addition, during migraine attacks, plasma levels of CGRP rise. After treating a migraine attack with a triptan, levels of CGRP fall because triptans actually block the release of CGRP. Yes, Olesen and Masudashina have shown us that infusing CGRP can trigger migraine attacks. And finally, based on all of this evidence, a number of CGRP targeted medications have been developed, and all of them work. They're monoclonal antibodies that are given monthly or every 3 months that work for migraine prevention. There are Gepants that are given both as acute treatment, and now one is also approved as a preventive treatment and another is coming. So the fact that targeting CGRP is effective in treating migraine confirms the hypotheses that were generated from the previously generated migraine and CGRP links. So looking at the CGRP receptor antagonists in migraine, one is called Rimegepant. It is approved as an acute treatment for migraine. It has a Tmax of 2 hours, a half-life of 5 to 7 hours. Another approved Gepant for migraine is Rimegepant, ODT. That's an orally dissolvable tablet that people can let melt either on top of or underneath their tongues. Rimegepant ODT is currently approved both as an acute and as a preventive treatment. It has a half-life in its ODT formulation of an hour and it has a Tmax rather of an hour and a half and a half-life of 11 hours. Two drugs that are in phase 3 testing for migraine are also available. Atogepant is one drug, and that drug has a positive phase 2 and a positive phase 3 study in migraine prevention, administered with a daily dose. Another drug in development is Gepant, which is being developed both as an intranasal acute treatment and as a tablet for prevention. Phase 3 is ongoing. The nasal spray has a short half-life, and the hope is that that will translate into a more rapid onset of action. It may be useful to contrast monoclonal antibodies and Gepants. In the migraine space, the monoclonal antibodies and the Gepants both target CGRP. The monoclonal antibodies are 30 times larger with a molecular weight of 150,000 Daltons. The CGRP target for the monoclonal antibodies could include the ligand, the CGRP peptide itself, or the receptor. Gepants target only the receptor. The Tmax for these drugs are very different. The shortest Tmax for a monoclonal antibody is the one for the intravenous drug eptinezumab, but for the subcutaneous drugs, the Tmax is 6 days, and there are 3 of those agents. And for Gepants, the Tmax is 30 minutes to 2 hours, depending on the drug. Half-lives for monoclonal antibodies are quite long, 4 weeks on average, which means that after administering a subcutaneous monoclonal antibody, if you want to wait 5 half-lives, that is basically 5 months. The Gepants have half-lives that range from 5 to 12 hours. The monoclonal antibodies are eliminated through catabolism, the Gepants through hepatic, renal, and biliary routes. Administration of the monoclonal antibodies is subcutaneous or intravenous, whereas the Gepants are administered orally by ODT or intranasally. And the clinical use of the monoclonal antibodies is for prevention, and the Gepants, which also target CGRP, can be used for acute or preventive treatment. So let's talk a bit about Gepants for the acute treatment of migraine. And there are 3 agents we're going to talk to: Ubrogepant, which is approved, Rimegepant, which is approved, and the Vigepant, which is in phase 3. So looking at the Ubro program first, there were 2 pivotal phase 3 studies named Achieve-1 and Achieve-2. Each study had as its objective to evaluate the efficacy, safety, and tolerability of Ubrogepant versus placebo for the treatment of a single migraine attack. People treated pain that was moderate or severe, and the per protocol primary endpoints, as recommended by the FDA and indicated in the protocols, were 2-hour pain freedom and 2-hour freedom from the most bothersome symptom. Most bothersome symptom is a symptom the patient designates at the time of treatment as the symptom that disturbs them the most, selected from among photophobia, phonophobia, and nausea. And the most frequent MBS patients select is phonophobia. These were both studies where patients were randomized 1:1:1 in the Achieve-1 study to placebo, Ubro 50, and Ubro 100. In the Achieve-2 study to placebo, Ubro 25, and Ubro 50. The baseline and demographic characteristics across treatment groups were similar in all the studies. Mean age was around 41. The sample was about 88% female and about 82% white. So looking at Achieve-1 data, and here we're looking at UBRO 50 and UBRO 100, what you see is statistically significant separation for pain freedom at 2 hours for UBRO versus UBRO 50 and UBRO 100 versus placebo. And similarly, you see a statistically significant separation from the 2 UBRO doses and placebo for absence of the most bothersome symptom. In Achieve-2, we were looking at 25 and 50 milligram doses. And again, what we see in this study is that the 50 milligram dose separates on 2-hour pain freedom and separates on freedom from the most bothersome symptom. The 25 milligram dose was statistically significant for 2-hour pain freedom, but not freedom from the most bothersome symptom. So what we see across these two studies is that 50 milligrams worked in both studies, 100 milligrams worked in the one study where it was tested, and the 25 milligram dose failed on its primary endpoints. Now, this study had a number of secondary endpoints that were hierarchically linked using the gatekeeper approach. What I want to highlight for you is pain relief at 2 hours, which was 60.7% and 61.4% for the 2 doses in Achieve-1, and 60.5 and 62.7 for Achieve-2. So the range of pain relief was similar to the range that was seen in the previous triptan studies, though the 2-hour pain-free rates were a bit lower than what was previously seen. So there were long-term safety studies for Gepant. One study followed people enrolled in Achieve-1 and Achieve-2. Another study was a phase 1 study in healthy adults where volunteers took medication 2 days on, 2 days off to just demonstrate or assess safety in a higher dose group. The bottom line is that treatment-related adverse event rates in the long-term safety studies were 10 or 11% for the long-term follow-up of Achieve-1 and Achieve-2, and a bit higher in the higher dose long-term safety study. But overall, the safety profiles looked very good. There was a concern about hepatotoxicity from prior compounds in this class, but no evidence of hepatotoxicity for Gepant, or in fact the other drugs in the Gepant class that are in development. And this slide summarizes the liver safety study. Major point is there are no potential cases of Hy's law, which would be an indicator of significant hepatotoxicity. And when you compare the rates of LFT elevation across the treatment arms, they're actually quite similar with Gepant 100 and with placebo. So one of the issues is how do we time our dosing of Gepant or other Gepants to assess the benefit of Gepant in mild pain when the study is focused on moderate or severe pain. A post hoc analysis was conducted comparing mild versus moderate pain in the long-term safety study. This is a very large database that included 1,254 participants and over 21,000 attacks, about 20% of which were treated while pain was mild. So here we're looking at pain-free rates in people treated when pain was mild versus pain-free rates when pain was treated when moderate or severe for Gepant 50 and Gepant 100. And what we see is that the pain-free rates when we treat mild pain nearly double relative to the pain-free rates when we treat moderate or severe pain. And similarly, when we look at the benefits of treatment on associated symptoms. We see that rates of freedom from photophobia, and nausea are also always significantly higher when attacks are treated during mild pain rather than during moderate or severe pain. And to me, this study supports the notion that Gepants are best given while pain is mild. And for that matter, I believe all acute treatments for migraine are best given while pain is mild. So the conclusion from the Gepant section is that Ubro in doses of 50 or 100 milligrams is an effective acute treatment for migraine. Treatment's more effective for mild pain, and tolerability levels were excellent. Now let's move on and consider the second Gepant for acute treatment that's already approved, and that is Rimegepant. And I'm going to show you first a phase 2 dose ranging study because it's the only head-to-head comparative data we have assessing a Gepant in relation to a triptan. There were a total of 3 studies with Rimegepant 75 milligram tablets, and all the studies were positive on their co-primary endpoints, which were identical to the Gepant co-primary endpoints, 2-hour pain freedom and 2-hour MBS freedom. And all these studies also demonstrated safety. I'm going to highlight the study of the 75 milligram orally dissolving tablet formulation because that's the treatment that's approved. And I'm going to briefly touch on some of the other studies as well. So here we're looking at placebo, sumatriptan 100 milligrams and Rimegepant 75 milligrams in this phase 2 dose ranging study. What we see is the 2-hour pain-free rates are 15% for placebo, 35% for Suma, and 31% for Rimegepant 75. So on this endpoint, Suma has a slight edge. When we look at pain relief at 2 hours, results are 72% for Suma and 72% for Rimegepant, nearly identical. When we look at nausea freedom rates are higher for Rimegepant than for placebo. So overall, my interpretation, given the relatively modest sample size, is that in the head-to-head study, sumatriptan and Rimegepant 75 provide approximately equal levels of efficacy. So let's look now at the 75 milligram ODT dose. And I want to point out that for the Rimegepant tablet, the Tmax takes 2 hours. For the ODT, it takes 1.5 hours. And this contrasts with what we see for rizatriptan, where the ODT and tablet do not differ in their kinetic profiles. And the hope was that Rimegepant ODT would be a little faster than the tablet based on its shorter Tmax. The objective here, though, was to compare Rimegepant 75 milligrams with placebo on efficacy, safety, and tolerability in the acute treatment of migraine. This was a very typical patient population for a migraine trial. And what we see when we look at the demographics and baseline characteristics, that it's again, mean age right around 40, predominantly female, with photophobia once again being the most frequent, most bothersome symptom. So looking at the efficacy results, the co-primary endpoints were 2-hour pain freedom and 2-hour MBS freedom. We see for Rimegepant a 21% 2-hour pain-free rate versus 10.9% for placebo, and 35% MBS freedom versus 26.8% for placebo. Both those differences are highly statistically significant. When we look at pain relief at 2 hours, it's 59.3%, right around 60%. And in this particular study, there were multiple endpoints that were listed and hierarchy, which were all highly statistically significant. The graphic at the top on the right-hand slide summarizes the key results from the study. So pain relief became significant at 60 minutes and remained so at 90 minutes and 2 hours. And we also saw sustained pain relief that was statistically significant versus placebo at 24 and 48 hours. In terms of return to normal function, that too achieved statistical significance at 60 minutes and remained significant at 90 minutes, 2 hours, 24 hours, and 48 hours. When we look at pain freedom, we see that significance was achieved at 90 minutes and persisted at 2 hours, 24 hours, and 48 hours. And in the panel at bottom right, we're looking at pain relief, and we see that there is some hint of Rimegepant separation from placebo at very early time points, but it does not reach significance until 60 minutes. So in terms of tolerability and safety, Rimegepant was well tolerated and similar to placebo. The most common adverse events were nausea and urinary tract infections. There were no treatment-related increases in transaminase level greater than 3 times the upper limit of normal, and no subject experienced elevations of bilirubin either. So our conclusion from this study is that the ODT formulation of Rimegepant delivered rapid onset of pain relief with a single dose, and that it was significantly superior on co-primary endpoints, including pain freedom and MBS freedom at 2 hours, and superior also on 21 consecutively pre-specified, hierarchically tested efficacy outcomes with a safety profile similar to placebo, including liver function testing. So Rimegepant is the drug being developed for intranasal treatment, and what we see is that for 2-hour pain freedom, the 10 milligram dose separates from placebo, but the 20 milligram dose just misses separating from placebo. And for 2-hour MBS freedom, we see statistically significant separation from placebo. When we look at the time course of pain relief, we see a hint of statistical separation at 15 minutes, continuing at 30, 60, and 120 minutes. And the hope is that for this drug, the intranasal delivery and the shorter Tmax will ultimately translate into more rapid relief of pain and perhaps more consistent benefits in people with prominent nausea or gastric paresis who have difficulty with oral therapies. So to summarize Gepant efficacy, Rimegepant in 50 and 100 milligram doses achieved both co-primaries and achieved 1 and achieved 2, and both those doses are marketed. It was superior on multiple endpoints, though not nausea freedom. The long-term safety study shows greater benefit when pain is treated while mild. For Rimegepant, it met the co-primaries with the 75 milligram tablet, which is not marketed, and the 75 milligram ODT formulation, which is marketed. It again showed superiority on multiple endpoints, though again, not on nausea freedom. The ODT formulation has favorable data for Tmax and earlier separation from placebo than the tablet based on cross-study comparisons, though there are no head-to-head comparisons. For Rimegepant, the nasal spray has a favorable Tmax, a relatively rapid onset, and its role may be in patients for whom oral therapy is suboptimal. Rimegepant is also approved as a preventive treatment for migraine with every other day dosing, and Atogepant is a novel Gepant, which has a phase 2 and a phase 3 study establishing efficacy in the treatment of episodic migraine. Questions that arise: are triptans more effective than Gepants? When and how should Gepants be used? And will Gepants work in patients receiving MABs? Well, comparing triptans across studies, triptans have the edge in 2-hour pain freedom, and the 20% 2-hour pain-free rate for Gepants is modest. The cross-study comparisons are hazardous, particularly when the studies are conducted decades apart and the study designs differ. The 2-hour headache response rates are similar for triptans and Gepants, and in the only head-to-head study, sumatriptan and Rimegepant, in my view, perform quite similarly. Gepants are for people whose needs are not met by triptans for reasons of poor efficacy, poor tolerability, concerns about cardiovascular safety, or concerns about medication overuse. So the head-to-head studies, to me, are not all that clinically germane. And in addition, I'll point out the clinical trials measure population averages. And so there are some patients who don't respond to triptans who respond quite well to Gepants, and that proves to be clinically important. So how should we think about when to use CGRP small molecule receptor antagonists? Well, for one thing, they have a distinct mechanism, and therefore in triptan non-responders, switching up the mechanism may well be a way to get greater efficacy. Because these drugs do not constrict blood vessels and do not have contraindications or precautions for patients with cardiovascular disease, they're certainly appropriate in patients with CV contraindications. Broadly, they have a long half-life. So if you're looking for sustained benefit, or if you have a patient with recurrence, Gepants are worth considering. And there is no evidence as of yet that these drugs cause medication overuse headache. And in fact, even in long-term safety studies, when people take Gepants acutely on a regular basis, monthly migraine days goes down, not up. And so the hope and belief is that these drugs won't cause medication overuse headache the way triptans, barbiturates, and opioids do. In addition, they offer opportunities for novel treatment strategies. So while Gepants work in patients taking monoclonal antibodies, the emerging evidence suggests that they will. Initially, there was some concern that 2 drugs that targeted CGRP might not work, but case reports and clinical theories and real-world studies all suggest that Gepants work on top of monoclonal antibodies, and certainly it's been my practice to use them. Another novel treatment paradigm that may be made possible by Gepants is what's sometimes called preemptive therapy. And here the idea is to treat in anticipation of a predictable attack. Now, of course, preemptive therapy has not been established for Gepants, but the broad idea is if someone is in a period of high risk for migraine, you might treat in anticipation of the attack. And you might do that, for example, for menstrual migraine, for stress-related migraine, for weekend migraine, or for very important occasions. The reason Gepants may be good drugs for this novel paradigm is that they tend to have long half-lives, they tend to have few adverse events, and they don't pose a risk for medication overuse. So I believe that preemptive therapy is an area that merits additional exploration. The other paradigm that becomes possible with Gepants is using an acute and preventive therapy with the same agent. So with Rimegepant, for example, the drug is approved for every other day dosing as a preventive treatment. And if a breakthrough headache occurs, rather than rescuing with a different agent, it is possible to rescue with an extra dose of Rimegepant instead. And similarly, if people are on Rimegepant acutely and they experience a short-term headache exacerbation and need preventive therapy, perhaps they could use the Rimegepant preventively on a short-term basis and then go back to acute treatment. I want to point out that we use this strategy for transcranial magnetic stim and supraorbital TENS, both of which are also approved for acute and preventive treatments. And although Rimegepant is the only Gepant studied for this dual therapy, my supposition is that Gepant might work in a similar way, but again, additional studies are needed. So with that, I'd like to thank you for your attention and hope that as treating neurologists and clinicians, that you enjoy the vastly expanded therapeutic armamentarium that we have to help our patients with this disabling disease. Thank you so much.
Terrific. Thank you so much for that amazing talk, Dr. Lipton. And welcome everyone to the live Q&A. Before we begin, I would like to recognize that this session is supported by an independent educational grant from AbbVie Incorporated. And now we will begin with our first question for this lecture. Do Gepants work on top of monoclonal antibodies that target CGRP?
Well, so that's a great question. And hi, Steph, it's really nice to be here. Let me say that the reason it's a good question is that monoclonal antibodies either bind the CGRP receptor or the CGRP ligand, the molecule itself. Gepants are small molecule CGRP receptor antagonists. So some people predicted that maybe Gepants wouldn't work on top of monoclonal antibodies because the CGRP system was already blocked by the monoclonal antibody. Although definitive evidence isn't available, the clinical practice experience and post hoc analysis of trials data suggests that Gepants do work on top of monoclonal antibodies. And there's a study that I presented at the American Headache Society just a few weeks ago where we used the app Migraine Buddy to identify people on Gepants and looked at how well Rimegepant worked on top of monoclonal antibodies. And we saw in an open label, uncontrolled, real world observational study that they were really quite effective. And we didn't see any signal either to suggest that the combination caused any sort of incremental adverse event.
As a follow-up question in that line, many of us wonder whether these are class responses. And by what I mean by that is if somebody responds to a monoclonal, are they going to respond to a Gepant or vice versa? What have you seen and what would you theorize?
Well, so there's been a little bit of work, and in fact, there was another abstract at the American Headache Society that asked the question, is response to a Gepant predictive of response to a monoclonal antibody and vice versa? And again, this was another open label observational real world evidence study. And the authors concluded that there was not much cross prediction. Now, of course, that's, when you look at cross prediction, a lot of people respond to Gepants, a lot of people respond to monoclonal antibodies. So based on chance alone, a lot of people would respond to both, but there was not evidence that Gepant response predicted monoclonal antibody response or vice versa in the one study I'm aware of that looked at it. On the other hand, Dave Dodik's group did an observational study that looked at predictors of Rimegepant. And in their study, they found that response to a monoclonal antibody was one of the better predictors of response to a Gepant also. So right now, the evidence is a little bit ambiguous. I mean, my approach is, if somebody is on a monoclonal antibody and they need an acute treatment and they're an appropriate candidate for a Gepant, I try it. And, of course, the great thing with acute treatment is you treat a few attacks. If you don't get the results you're looking for, you can change therapies. The other thing I want to add is that we know that most acute treatments work better if they're taken for mild rather than moderate or severe pain. And there's a gap between the way clinical trials are designed and the way we give acute treatments in practice, because trials treat moderate or severe pain. In practice, we treat mild pain. And as I showed in my talk, there is systematic evidence that Gepant works better when it's used to treat mild pain than moderate or severe pain in terms of the pain-free rates that are achieved.
Yeah, I'm not sure I'm ready to come down one way or another on it either. I have not been struck with a clear pattern, but like you said, it's hard to predict based on just the clinical trial data because it's difficult to compare one trial to another. That kind of leads into our next question, which is, how do you rationalize the relative small effect of Gepants over placebo? If the receptor targeted, why isn't there a greater response? Or why is the placebo response perhaps higher in these studies? Do you think the placebo response is excessively high?
Yeah, so part of the reason 2-hour pain freedom is considered a desirable endpoint in a regulatory context, and part of the reason the International Headache Society recommended 2-hour pain freedom as a primary endpoint in acute treatment trials is that generally placebo rates are lower, much lower looking at that endpoint than looking at headache response, which means making the transition from moderate or severe pain to pain that is either mild or absent. So in the Gepant and Rimegepant trials, the placebo rate is, broadly in the 12% range, which is slightly higher than what we saw for 2-hour pain-free rates in the triptan trials. Now, the studies were conducted on average 20 years apart, and the primary endpoints are different. And the Gepant trials were done with electronic diaries. The triptan trials were done substantially with paper diaries, at least in early days. So the head-to-head comparison across trials is difficult, both for placebo response and active treatment. It is a fact that the 2-hour pain-free rates or the placebo-subtracted 2-hour pain-free rates for Rimegepant and Gepant are lower than what we saw in the triptan trials. But I think inferences are complicated by 20 years of difference and the difference in study designs. There's only been one head-to-head study comparing a Gepant with the triptan, and that was the phase 2 study of Rimegepant, and I showed the data on that in my talk. And in that head-to-head study, Rimegepant and sumatriptan performed quite similarly. So Rimegepant had a small edge at 24 hours. Sumatriptan had a small edge at 2 hours, but the differences were really quite marginal. So I would say, and the other thing I would point out is that the headache response data, moderate or severe pain goes to mild or no pain, looks quite comparable for triptans and Gepants. I think what happens is that Gepant and Rimegepant, and this is slightly ironic given the title of my talk, but I think Gepant and Rimegepant have benefits that don't fully kick in within the first 2 hours. It takes 4 hours to get the full benefit. So I would not say they're less effective, but I would say the onset of pain freedom may be a little bit slower.
Excellent response. We have time for one more question, and it's about vascular safety with Gepants. How do you handle a patient with a recent vascular event who's either on a Gepant or you're thinking about starting a Gepant on? How long would you wait? Do you wait at all?
So that's another great question. And one of the advantages of Gepants over triptans is they're not vasoconstrictors. And of course, they don't have the class labeling that contraindicates their use in the setting of vascular events. And similarly, Gepants don't have the precautions that say, don't give these drugs to patients who have multiple vascular risk factors. My approach is that I use Gepants in patients in whom triptans are contraindicated, but in the setting of an acute event or a very recent acute event, I would hesitate using Gepants for two reasons. One is that the rate of recurrent events is elevated for a period of time, and I wouldn't want the patient to have a coincidental event attributed to the drug. The other reason is a more theoretical reason that CGRP is the most potent vasodilator in the body. So even though these drugs are not vasoconstrictors, they do block a vasodilation system. And in the setting of recovery from ischemia, it may be that CGRP-mediated vasodilation is an important part of maintaining perfusion. So I would typically wait 6 months before giving a Gepant, but there is a risk-benefit component to the decision. So I don't think there's a hard and fast rule. It's based on risk and benefit to a particular patient.